Welcome back to the Barbell Therapy Podcast. I am your host, Dr. Brett Scott. Along with me here today is my mentor, Dr. Erson Religioso, also known as Modern Manual Therapy. So today we're going to talk a lot about recovery and are you recovering? Are you overtraining? And are you just over complicating the whole topic of recovery on yourself? And some fun facts we have, some upcoming things is I'll actually be starting a course with Erson called Modern Barbell Therapy. So we'll be rolling out a course online and in person soon where I will be teaching clinicians how to look at strength training and how we can put that into or integrate that into the physical therapy space or movement practice space, and giving clinicians the tools they can use to assess things like the deadlift, the squat, the bench press, and even the Olympic lifts, and what we can do to treat athletes a little bit better than we have in the past. As a lot of athletes have come to me where rehab has failed them. So I hope I can bring this to other clinicians that might not have a complete understanding of strength sports and strength athletes and how to best manage them. So look for that in the near future. And Erson, thanks for coming on.
Yeah, thanks for having me, Brett. It's always good to be on your podcast. I know we swap every once in a while, but yeah, I mean, in terms of your course, I think that is really needed I mean, I've lifted my entire life. I used to be quite a bit bigger than I am now because mostly I just run. I do lifting enough to maintain. But yeah, even after seeing a couple of your modules, I just thought I knew how to bench press safely. And then after seeing, someone who almost set the world record in juniors, uh, in her form, I just thought, I don't know anything about bench press. This course is so needed. Yeah, I think there's a lot of misconceptions about how to do things and how to regress things, how to progress things, and how to recover. Clinicians, even if they have lifted regularly, are not often strength coaches or perform, they don't typically work with only that population. And even if you are a coach, you may not know how to treat or manage injuries. So I think it is a really needed thing, because so one thing I'm sick of hearing, whether it's for any kind of athlete really, or anyone who enjoys a particular activity, is just not to do that activity. There's always ways around modifying the activity and doing the things you love, and taking it away completely isn't usually a good answer.
Yeah, and to lead right into that with our discussion for today is recovery. And so from my perspective of what I've seen over the years is people come in and it's like, oh, I just stopped doing this completely because I couldn't do it and it was hurting, and I tried everything and it just didn't work. And part of that has been diving deeper with these patients and looking at, is it the actual activity that was bothering you, or is it something environmentally with your recovery or what you're doing, or maybe something you're not doing? And I think these days recovery is looked at as this activity where you have to go to one of these new recovery spas and you sit in the Normatec for an hour and then you get a liquid IV drop, and you're making sure you're sleeping 10 hours and taking all these supplements when really
Don't
when
forget about pure oxygen too.
yeah, we need to get in the hyperbaric chamber and
Yeah.
also the ice freezer there for 30 seconds. But really, like you said before, we've gotten along just fine up until this point without these things. And so, what other things are we doing that we can look at as a patient or someone that's in pain that we can do to get better?
Right. I think one of the things is when someone says, X exercise ended up making me worse. I always say it's the 2 hour rule. The 2 hour rule in general is if you're doing a certain activity, or in our case, if we're doing a certain treatment, people say, like, oh, so much better or so much worse. Many times you do a mobilization as a therapist, you do some kind of treatment, or you prescribe a certain exercise. You're like, oh man, that made me so much worse. Or you think running makes your knees worse, or you think deadlifts make your back worse. Typically, if something's going to make you worse, it's going to flare you up while you're in the middle of doing it, and not 2 to 3 hours later. If it's 2 to 3 hours later, or even longer, like the rule is, if it flares you up during, or especially within 2 hours of whatever it is you're doing, whether it's a treatment or an exercise or activity, it could be that activity. If it's like 24 hours later, like a lot of patients, like, oh yeah, man, I think you did whatever you did, it made me so much worse. Oh, when did you start hurting? Oh, like 2 days later, or like the next day. If it's the next day and I saw you at like 8, 10 a.m., there's a big space between whatever it is we did that day and everything else you did. There's so many variables. It's often something else that at least added on top of it. I'm not going to completely absolve myself of making you worse, but there's too many variables to say, I only take credit for your worsening within 2 hours. And the same thing should be said of your own workouts too, right? The deadlifts really make you worse? Or is it the fact that you sat all day before you did deadlifts, you like warmed up by going to the locker room to change out of your work clothes, and then you immediately started deadlifting, and then you sat the rest of the day, you went back to your job where you sat the rest of the day. Is it all the sitting and the lack of movement variability that's making deadlifts hurt your back, or are deadlifts really bad for your back?
Yeah, exactly. And I'll always go back to these things with patients of exactly. I'll use something similar to that 2 hour window rule as well. And looking at, well, what else did you do that day or the day before that could have, potentially flared you up, if you will, where, like you said, like if deadlifts don't bother you while you're doing them, but, if you're a manual labor, or have a manual labor intensive job and you're flexing all day, and then that seems to hurt your back by the end of the day, and then you go sit on like the chase lounge with your legs up and you're kind of in this slumped bent position all day. We can't just blame deadlifts for that. So a lot of it can just come down to changing your position, or even like things like overhead press tend to bother some people, or people think they bother them. And if we find they have like a spot positive Sperling's test where we put their head back and that recreates a shoulder pain, um, but they're spending most of their day overhead and then they sleep on their belly with their head like this in that same position, we can kind of know that those things are going to attribute to a sensitivity there. That instead of going to a hyperbaric chamber and all these things, what what would you propose we could do, Erson?
Well, I'm really big on movement variability, right? Like for most of my spinal patients and some of my extremity patients, limbs, say like arms and knees and whatever, I also recommend just go on 2 regular walks a day. Make sure that you break up, especially if you have a sitting job, make sure that you break up sitting as much as possible. I never understood sitting jobs, especially when people have low back pain. They're like, oh man, it hurts so much to sit, but literally you just sit all day and you don't ever change positions. I worked for an insurance company for about 5 or 6 years while my clinic was just starting up. And I would always think to myself, I'm going to do one more phone call. I'm going to do one more case. Meanwhile, I actually had raging sciatica. My leg was going numb. And I would just think, I'm just going to do one more case. I could tolerate it. But, before I knew it, 4 or 5 hours had gone by. And it was very hard for me to calm it down then. So I developed this strategy, which I also tell, in addition to the just daily walks, to kind of break up the activities and prevent things from like forward bending and sitting to from adding up. I started drinking like 20 ounces of water almost every hour, because what I always tell patients is you're going to go to the bathroom. When you go to the bathroom, then you end up, then refill the water, and that is enough to prevent that from adding up, because you're sitting long enough to actually cause your back to hurt or your leg to go numb or your arm to go numb, but you're not going to pee your own pants. I mean, and then if you end up wearing Depends by trying out this strategy, then these strategies are not going to work for you, and there's probably some other issues. But that ends up being a good strategy because people literally have to be reminded. If they're not reminded by their pain, they're going to be reminded by their bladder. So that's one of my favorite strategies to tell all spinal patients, and it usually doesn't hurt to be more hydrated anyway, because most people think their urine should be the color of Mountain Dew when it should not.
This is very true.
Yeah,
Our 11-year-old came out of the bathroom the other day actually and said, "My pee was clear. Is that okay?" And I was like, "Yeah, it's a really good thing." Actually, that's the color it usually should be. And she
yes,
was
yes,
she was concerned that it was
that's
not
hilarious.
not a yellow color. But
You're what we call
anyways,
hydrated.
yes, and these things are so simple. I actually had a case similar to this come in the other day of someone I've worked with on and off for a while, and he's had this referred hip pain. He works as a contractor all day, and he just drives around to different job sites, gives quotes, but he really doesn't get out of his car much, from what I've gathered. And so he's sitting in his car 8 to 10 hours a day and not really getting out much. And every time he gets up, if he every time he goes on vacation and he's snowmobiling, he's doing all these things, his back and his hip don't bother him. Um, every time he gets back to work, it gets worse. And so we discussed a lot of different things, and my treatment plan for him was get out of your car and walk more, do more repeated extensions, try to vary your position in your car as much as you can. And he was just flabbergasted that I didn't give him any crazy exercises to do or any crazy manual therapy, because he keeps continuing to get better when he just doesn't sit in a position for a prolonged period of time. It doesn't have
Right.
to be that complicated.
It doesn't.
And
Yeah, people are really shocked that they are often doing this to themselves, and the solutions can be as simple as move more often,
yeah,
right? The best position is the next position.
that's right.
Yeah, it's not like you have to sit with a lumbar roll. You have to sit with some kind of pneumatic posture support. If you just moved around, like I'm sitting on a ball right now, I'm just like, you just move around a lot more. Sitting won't add up.
Yeah. And so we talk a lot too, and a lot of people that have seen me before know that I am big on repeated motions. A lot of people
Where'd you
will,
get that from?
yeah, I got it from this guy right here.
Okay,
So people have done plenty of prone press ups with me, repeated extensions and standing, side glides. People know it as the little teacup exercise or little teapot exercise. So, Erson, do you want to talk a little bit about that and why some of these exercises can be so important for someone with either back or neck pain, or even lower or upper quarter pain?
sure. The thing with extension, and I always liken neck extension where your head is look head and eyes look up. Your forehead should be able to within a certain age range should be able to be forehead parallel to the ceiling, which most people think that's crazy, without having to backward bend your back like you are doing a limbo contest. And your backward bend, you should be able to backward bend not quite as much as you forward bend, unless you're like a hypermobile person, like a gymnast or a dancer or something. You should be able to backward bend quite a bit as well. You know, the thing I liken the spine to the elbows. If you think of your elbows, the way that we moved our elbows would have problems if we treated them just like our spine. So the thing with our elbows is that when we are walking around, our arms are typically straight unless we're running, and our elbows are flexed. But most of the time, when you're walking around, you move your elbows through a full range of motion. Your spine, very simple research basically shows that the average person bends forward 2 to 3 thousand times a day, and that's independent of deadlifts and squats and any other program that you might be doing or sport where you're bending forward a lot. And you add up on to the fact that you are sitting in a slump position. In addition to those bending forward to 2 to 3 thousand times a day, it becomes exceedingly hard to extend your spine. So back to the elbow thing, and what I always tell patients is if you flexed your elbows 2 to 3 thousand times a day, but then instead of holding them at your side straight, you kept them all the way flexed and you held them there the rest of the day. By the end of the day, by the time you extended them, how would they feel? Most people say like, oh, it wouldn't feel good. It would feel pretty stiff. But that just after one day. You do this day after day after day, and it really adds up. And then you're like, oh, I hear deadlifts are good for runners. Everyone should do, strength training is great for injury prevention. Yes, it is, but I mean, it's injuries and pain tend to happen when your activity exceeds your capacity. And if you don't have the capacity to load or extend, and all of a sudden you end up doing like snatches or deadlifts or something that requires spinal extension, it's not going to feel good if you literally don't go into extension. But if you just extended more regularly, maybe you wouldn't have all that low back pain.
Yeah, exactly. And the other thing too, I think, is people get fearful of extension sometimes because it can hurt sometimes when they first start to do it. And do you want to discuss a little bit about that too? Because we have a lot of patients that will start there and they get a little apprehensive of like, I don't know, every time I've bent my back in the past, it's hurt. So what kind of things do we need to think about when we're trying to restore our extension, whether it be in our neck or our back?
Sure. Well, I mean, if this is also a video podcast.
Yeah.
Okay,
Yep.
yeah. So I have these models, right, that are very accurate, and I just show them, your spine is supposed to extend and it's supposed to flex, just like how your elbow is actually supposed to flex and your elbow is supposed to extend. For some reason, people don't fear hip extension. They don't fear elbow extension. They don't fear knee extension. And people always think like, well, I'm going to crank on my hamstring. I'm going to crank on other things, but they don't. Not to say that you should crank on your spine, but it's again goes back to my elbow example. If you do this day after day after day, this is certainly going to feel stiff, and it might even hurt to do if you've been holding your elbow like this for years, and then someone's like, hey, you know what? Start doing this. And it's not like prone press ups and extensions, they're a great exercise, but if you haven't done it in a long time, it's certainly going to feel stiff and possibly hurt. And that's where certain treatments like manual therapy, needling, soft tissue work, that kind of enables you, and it kind of convinces your brain that these motions are okay to do and these positions are okay to do. Because if you do something enough, your nervous system is either going to say, give it a green light and say, this is okay to do. Um, and then, but if you don't keep up with it at a high enough dosage, you just lose the ability to do it again because your brain is always trying to protect you. And if it thinks that a spinal extension is dangerous, and you maybe you go to a chiropractor or a PT, they do some manual on you, you get extension for like an hour or two. If you don't keep up with it at a high enough dosage, you lose it. That's where that whole term called grooving comes from. You know grooving?
Mm-hmm.
Yeah. Grooving is kind of like if you're skiing or snowboarding down a mountain, the first couple times you make the path, it's hard to make the path. So once you make the path, you have to continue grooving that path to make it set. And it's the same thing as with mobility. Mobility is something that also, in a way, you have to train. If you're an athlete and you've lifted a lot, you have a certain training regimen, and you're disciplined enough to actually lift at a high enough intensity to hypertrophy and build up muscle. But if you don't train mobility, if you just kind of stretch when you need to, assuming mobility is the problem, but you don't groove it, you don't groove the path, it's just going to snow and the path is going to be gone again. Mobility is something that needs to be trained, and it needs to be loaded. It's not only that stretching needs to be done, but one of my favorite things is to gain the mobility and then load it with weights in the new mobility. It's not just like active motion only. Resisted into the new range is also very important. You need to load up those joints as well. So
Well, on that aspect too, I don't even tell people we're stretching anymore,
yeah,
because I think stretching has a connotation that it's something you do when it hurts or anything else. Where we do mobility training, where this is going to be a regular part of your regimen, where we need to do this regularly, hopefully daily, maybe 3 to 4 times a week, depending on the intensity and the duration of it. But it's certainly something that's can be part of your training, or maybe this is part of training your recovery and just getting you out of the positions that you're in all day. Again, where we're flexing our spine 2 to 3 thousand times a day, recovery can be extending the other way, just a few times an hour even.
yeah, it could be going for walks. It could be swimming. Recovery doesn't mean sitting around and being a sloth. If you're one of those type A who needs to literally do something every day, you might need to actually take a break and literally do nothing like once a week. I mean, it might be good for you. Have a beer or wine or something, listen to relaxing music or do some mindfulness. But I mean, if you're one of those people that absolutely cannot sit still, like I used to be when I was in my 20s, I just like slap BFR cups on and go for a walk to make it seem like I'm still like getting a little bit of workout, and you might get a little bit of increased human growth hormone release with that. So you can still be active on your recovery days, but it shouldn't resemble a heavy intensity of what you're doing on your training days, because that's again, it's easy. It's an easy thing to remember. The injury or pain happens when your training or activity exceeds your capacity. You just have to build up a high enough capacity to do the things that your training involves.
And I think another question too that I think a lot of my patients or prior patients would have is with extension. And I get a lot of nerdy coaches and things too that like to nerd out over some of these things, but sometimes it's almost unexplainable. If we find, through your course and things too, if any other clinicians are out there listening to this, but we'll find limitations in like lateral tibial glide, knee internal rotation, hip internal rotation. And then sometimes I'll just put someone in prone on elbows or a prone press up for a few minutes. And all of a sudden,
And then it goes away.
and then
No,
it goes away.
they're all better. Yeah.
And why is that? So what is it about getting our spine out of flexion all day and turning it into or giving it some extension? What happens there?
Well, there's a lot of theories. I mean, the easiest way to look at it is like the neck rules the upper body roost, and the low back rules the lower body roost. I mean, I've seen people who've been referred to me for testicular pain, and extension made them better. I had a guy who had turf toe. He kicked something. He couldn't do planks or push-ups, and extensions made him better. And it really seemed like a turf toe, but no kind of toe treatment made it better, but spinal extension made it better. The guy who was referred to me for testicular pain, I'm like, I don't know why your doctor referred me, but I'm going to try this. And luckily, his testicular pain got better. I didn't palpate it, by the way. He just knew that he had testicular pain. Um, well, yeah, I think the easiest way to explain to clinical or non-clinical is that flexion tends to also place a load, a neurodynamic load, meaning like a stretching type uh, or extensibility type load on the nervous system. So if you have hip limitations, knee limitations, your nerves move between your muscles and your bones. I always say, just like assuming you don't have a super tight fitting shirt, it should move like with like your arm in a loose fitting sleeve. So if any part of the sleeve is tight, then that nerve could be a little restricted. Plus, when you flex your head, you flex your hips, you're essentially playing tug of war with the nervous system. Like if I was trying to get hamstring or hip extensibility, but I'm always flexing and I'm never extending, flexing places load on the nervous system from the spinal cord down to the nerve root. So you're always going to have less mobility at the distal end. If I pull on my head, like if by flexing forward and flexing my trunk forward, I'm pulling the spinal cord upward, but then I'm also trying to like stretch my hamstring or stretch my hip in some kind of like, like frog position or something like that, like tactical frog or whatever it's called. If you're doing that and your head is all flexed, like maybe try doing it with your spine and your head extended, because that way you're slacking. If I gave a lot of slack from the top of the rope, the other end of the rope is going to have more mobility. And that's one of the theories as to at least why I think extension, because it ends up slacking so many things, it also ends up slacking muscles that are typically tight, right? So slacking muscles that are tight would be like previously when a muscle has tight tone, that'd be like trying to get your arm not to move easily. But when you extend things, now the sleeve is loose, so the nerves can slide and glide a lot easier. That's why I think, spinal extension helps. Plus, also from a lumbar, but not so much cervical standpoint. Let's see if you can see this here. Where is my cut? So, can you see this?
Yep. That's a
Yeah,
good view.
it should be a blue nucleus that kind of pops out with flexion. So the blue nucleus should pop out. Do you see that?
Yep.
So
And
simply, if you have like a spinal, if you have like an actual disc issue, a lot of flexion makes the nucleus pop out,
oh, there
versus
we
a lot of
go.
extension makes it go in. So this is
That
actually a specific model that I had developed for me, where the chiropractor who invented these things and actually literally hand makes them. They're amazing models. His was red, and I'm like, well, can we make a blue nucleus? Because red nucleus always makes it seem like, oh, inflamed, and from a clinical perspective, it's nocebo. I'm like, let's just make it blue. So this is my blue nucleus model.
for anyone just listening to this on a podcast, you'll have to go back and look at our YouTube video because that's the coolest spine model I've ever seen, and I might have to get one of those.
I'll send you the link.
Yeah. Um, and kind of to wrap this up a little bit, are there certain individuals or certain reasons people shouldn't extend their spines like this?
Yeah, for sure. I mean, there are three outcomes of any possible treatment, movement strategy, exercise, whatever. It's better, worse, or no change. And people shouldn't extend or close down or load if it makes them worse. And worse isn't during the treatment; it is the lasting effect. Because someone can actually technically have pain every single time they do the motion, but if overall they feel better and they're walking and they're moving around, and they have better mobility afterward, it's technically okay. That's not really what I like to do. I like to actually make the treatments be as pain-free as possible and then have the net result of being better. But typically, again, if you think about someone who is in extension all day, they may actually need to flex. Like my wife is someone who typically has fear avoidance of flexion. She doesn't like the flex too much. She doesn't like doing deadlifts. She doesn't have great posterior chain mobility. She loves extension. She does extensions all the time. And after we've had several of our kids, we have 6 kids, so they're experienced at that. She's like, "Oh, my back hurts. Will you treat me?" And usually, what she means by that is, "Can I have a massage?" And normally, I'll say like, "Oh, have you been doing your extensions? Have been doing your exercises?" So she's like, "I tried my extensions," and this is again shortly after we had a child, but they're not working. I'm like, "Oh, well, let's try flexion." Because if you think about someone who has been in a huge anterior pelvic tilt, stuck in extension for an entire third trimester, that's 3 months of being more in extension than flexion. Other patients who I know, if you're a sway back, like meaning that you're overall stiff, if when you're standing up, your shoulders actually are in back of your pelvis, the majority of the time you're upright, you are extended, you actually might need flexion. But Mackenzie, who kind of came up with the whole concept of repeated loading, when I got certified in 2004, we're talking about a clinician who loaded someone 50, 60 times in flexion, 50, 60 times in extension, or even more. I've seen his diplomats extend someone for 45 minutes before they made a conclusion, which is really boring to me, but that's how their decision process goes. I kind of take lots of shortcuts. Mackenzie himself, when I got certified in 2004, said he had never seen an anterior derangement, which is what I call flexion rapid responder, meaning he had never seen someone rapidly respond to flexion. It's not impossible. It's not a unicorn in Santa Claus, but it's rare because the majority of people are flexing so much. But there are again certain body types, maybe even certain jobs, or even certain injuries. I also saw someone once who fell in her garden, but she fell in like a super hyper extended position. She responded to flexion too because her injury was extension. Most people have an injury based on flexion, and plus they've already been flexing their entire life. Then they go to a clinician who all they do is unload and stretch more. There's variations on flexion, and that's why it's not working, because it's just more of the same thing. There's not a one size fits all. It's not extension helps everyone. It's just that based on the law of averages, since most people are flexing and unloading, extension seems to be a more novel solution.
Mm. So the moral of the story is, if we want to recover better, make our joints and our body feel better and perform at a higher level, we should typically go in the opposite direction of where we usually are.
Usually, yep.
Yeah. Yeah,
It's
usually.
pretty simple.
Yeah.
It's pretty simple. Just
Uh,
just move well, move often, and move in the full range, your full available range as much as possible. Don't take your spine for granted, and just extend it as well. We extend most of our other joints, with the exception probably of our hips. Most of our other joints kind of go through at least 80% of range or so, but not our spines. Our spines are kind of like, we'll just stick to this 50% of forward. Forget about
mhm.
that backward.
We'll protect it as much as we can.
Yeah,
Um,
don't ever go backward.
yeah. And Erson, there anything else you'd like to add?
No, hey, you know what? If you find this stuff useful, I do post a lot of stuff which is generally helpful just to athletes and the public as well. You can follow me at Modern Manual Therapy on Instagram, Facebook, and YouTube.
Cool.
And look out
And
for our Modern Barbell Therapy course coming soon for PTs and for coaches as well, and any PTs, OTs, athletic trainers, chiro, sport, right, rehab-minded chiros, for
yep.
curious people, I guess.
Yeah, literally pretty much anyone that wants to learn more about dealing with strength athletes or people that like to lift weights that are in pain and you don't feel like you have the best handle on managing them as a movement provider, I would say this would be a good course for you. And so, yes, if you guys have any questions, I would definitely follow Erson's content, like he said. You can also shoot me a message as well at barbell.therapy on Instagram, or shoot us an email through our website, barbelltherapyandperformance.com. I can answer some questions too as well about what the course will contain, as we've recorded most of it now and we're just finishing up the final touches on it before we put it out there. So I hope you guys enjoyed this podcast, and I hope to see you next time.
Give them 5-star rating.
That's right. Yeah. Throw us a 5-star rating on the Google, Spotify, whatever podcast
Or
you
wherever
listen
you
to,
listen to podcasts.
or wherever you listen to podcasts, because that's one thing I haven't done yet as I'm trying to grow this podcast, is ask for ratings and subscriptions. So please subscribe to it
Right.
too.
All right.
Thank you, Erson.